I'm Alex Plum. I'm the Director of Development and Innovation at the Global Health Initiative, which is at Henry Ford Health System. Henry Ford is a very large not-for-profit healthcare system in the city of Detroit, headquartered in Detroit. We own 6 hospitals, about 30 medical ambulatory centers, outpatient clinics throughout the southeastern and central Michigan. We own an insurance group, we've got a medical group, a bunch of doctors that work for us, and a concentrated effort on really improving the healthcare of vulnerable and marginalized populations, both in Detroit and increasingly around the world. Henry Ford has had a dedicated interest in learning about solutions from outside the United States, and specifically looking to lower middle income settings to help us really think outside the box in terms of how we frame health challenges and then leverage good ideas to solve those. And so we've been coming to the Innovations in Healthcare annual meeting for, I think this is our 4th year, Henry Ford being here. And through that work, we've gotten to know some folks from the Robert Wood Johnson Foundation. And so together we said, let's do a study tour. And who better than to help put that together than Innovations in Healthcare by really looking and digging into who are some of the innovators that we could be learning from. We started that process really by doing a kind of a deeper dive both at Henry Ford locally and then Robert Wood Johnson for the sort of national culture of health, to understand where there are population level challenges that we could find similarities to explore on. And so we worked with Patricia and Eunice, and they were fantastic at helping us put together a little week-long trip, first in Rwanda and then another week in Kenya. We got up to Kisumu, we saw the folks from Luwala Community Alliance, from Afia Research Africa, had a really nice lunch with LVCT, which is based there in Nairobi, Jacaranda, so a lot of different organizations. And really the purpose was just to better understand from the innovator perspective kind of the driving force behind why they're doing what they're doing and how do the populations overlap with who we're serving. We were really, really excited to get involved in this project. Commonwealth has been a huge supporter of this kind of learning process, and I think that the learning is really, I think, about establishing equity, especially when you have an international project portfolio and you're working abroad, to be able to flip the question and say to folks, so we might be an expert in this one area, but we really want you to teach us in this other area, right? Even in Detroit, we do not deliver healthcare very well to our vulnerable and marginalized members of our community, and that's because we aren't incentivized to really critically address social determinants issues. And so the payment mechanism piece, which is I think what is pulling the 5 of us together, the 5 health systems on this project together, really is looking at those incentives and those payment structures that will help facilitate better care, better value-based care, right, for high-cost, high-need patients. The other piece is in many low-income areas, high-cost, high-need patients are the typical patient that you're seeing. Multiple comorbidities, and not just physical health, but behavioral health issues as well. And so trying to find a mechanism that will help support the integration of that care with a payment mechanism that will put the patient at the center, their family at the center of that work, and then an innovation or a care delivery model that that can really provide care to them. That's going to be that doesn't exist in the United States right now, right? But it does exist around the world. Because it's intuitive to so many countries. And that was why we wanted to go visit Rwanda and Kenya. It's why we do work in India and Nepal, a lot of places to learn from this, because it is intuitive that care will be housed in primary care. So for us, Henry Ford has a next-gen accountable care organization. We're participating in next-gen ACO. And through that work, we've got access to a little bit more flexibility in terms of what kind of services we deliver to our community. Those partnerships then have enabled us to better identify and to segment what are the populations we're seeking to drive care toward. And then looking to our partners like Mount Sinai, University of Arkansas Medical Sciences. I mean, they're kind of similarly situated hospital network pieces that are serving a not totally different population of patients. I was just talking to a colleague from University of Arkansas this morning, and we said, we really got to set up that visit. And that's kind of what these kinds of programs do. Surface some ideas, put these experts in the room together, surface some solutions, test them, and go see one another in action, and keep following up with each other. So I think we're going to get somewhere with that. Our global health program at Henry Ford, I think we're going into 6 years now as an organization. We've been establishing a culture at Henry Ford which prioritizes sort of this humble, humility-grounded, looking to developing world to drive solutions for us. That's a hard sell when you're talking to the medical, this sort of medical industrial complex, right? That who we are really as an organization. We've got some of the best thinkers in the world working with us, and so to say to them, "You're right, but not completely right," that can throw people through a loop. So part of this is building up that trust, kind of orienting folks to what to what the value could be from a lower middle income setting and why we look for solutions there. But the other piece, really, I think, again, it goes back to incentives, is ensuring that, in an operation that's still very fee-for-service, we're only starting to move into value-based, that we're continuing to advocate for our own institution to keep pushing forward, to keep making available opportunities for departments like ours to work with institutions, divisions, departments across the health system on these kinds of projects. And where we can, to start to see better value. Already, we've been able to identify a couple different populations, so specifically patients of ours who've got COPD, and thinking about new outreach, both discharge, engagement, patient engagement, family education, and then follow-up care procedures that have kind of payment mechanisms that have come out of the fore from those conversations, and that we're moving forward.